All right. Another exciting lecture about lung disease. You guys are in it for the day, huh? With all this. COPD is bread and butter pulmonary medicine, right? So this is something that we all see every day. And I think it may not be the most exciting topic, but I promise it's very it's very prevalent. We all experience this every day with what we do, our interactions with our patients, and probably a lot of our family members and friends who have lung disease. So we'll talk a little bit about. I know most of you in this room know a lot about COPD and work with this very frequently, but there's some recent updates that we'll go over and talk about. And I'll also just kind of mention, in addition to what Dr. Wells mentioned, this is the future of pulmonary medicine. When you talk about where we're going with treatment of asthma and COPD, it's biologic therapy. That's just the future of pulmonary medicine. So soon down the road, we are going to be talking about some of these biologic agents targeting COPD as well. That's kind of where we think that this is going. And there's already some research out there that's looking at treatment. And in fact, some of these guidelines that I'll be talking about now, as we learn more and more about this process, we are incorporating things like eosinophils into our algorithm and our discussion with COPD, not just asthma, on whether or not to add an ICS to the treatment. By ICS, I mean inhaled corticosteroid. I know most of you work with those inhalers, but just to kind of keep it in plain terms, steroids and the benefit of steroids with COPD from inhaled corticosteroid standpoint will be dependent on things like blood eosinophils. And so those are things that, everything is about risk versus benefit for us when we talk about treatment. And so I think it's certainly important. So anyway, thanks for having me, guys. We'll try to get through this briefly and painlessly, I hope, and answer some questions. I do not have any financial conflicts that are pertinent to this lecture. I am a paid consultant for Intuitive Surgical in the robotic space, but nothing to do with COPD. Most of my references that I put in here are related to the GOLD guidelines, the most recent GOLD guidelines. So you'll see some slides on here that are just straight out of GOLD. As Dr. Wells put some of the GINA guidelines up there on his slides. Similarly, I'll have the GOLD guidelines. So we'll talk about what GOLD is. We hear this term thrown around a lot, GOLD, and I'll just kind of give you some of the brief history about GOLD. And just go over some epidemiology. I'll talk a little bit about the staging. We'll talk about the differences between 2017 and 2023 and the big changes that you'll see in the terminology, and also why we are making those changes in the terminology. I'll talk briefly about pharmacotherapy, and then we'll just go over a couple cases. Okay, so we know that this is prevalent everywhere, right? We see this with so many of our patients, and approximately 10% of the population aged 40 or more in the United States have COPD. It is the third leading cause of death worldwide, and that was prior to or excluding the COVID pandemic, the third leading cause of death worldwide. Approximately 3 million deaths annually in the world and 120,000 per year in the United States. And that is expected to rise. And even though we are seeing smoking rates drop in this country, globally, we are still seeing both lung cancer and COPD rise. And I always kind of tell this story about one of the global lung conferences I went to recently, where it was in Montreal. We had this group of gentlemen from China who were standing under this global lung conference sign, and they were smoking cigarettes, and they're pulmonologists. And so me and one of my friends that I was there with at the conference just kind of chuckled at that a little bit, and then decided to go over and approach them and just talk through some things with them, just in terms of understanding maybe any cultural differences or where they are at within their country with interventions for smoking cessation. And it was a very interesting conversation. And what I was told essentially is that it is so ingrained in the culture that it's not really, that stigma that's associated with smoking that we have now created in this country through advocacy efforts, fundraising, tobacco settlement dollars, all of these things that we've done, that has not happened in China, right? So the prevalence of smoking is very high. The incidence still is going up in China and in a lot of the Asian countries, not just China. So we are seeing this. This is going to be continue to be a problem worldwide. And I think until we have, the same type of things globally, we're going to continue to see our patients with lung disease, COPD, emphysema, and lung cancer. Okay, so when you look at the impact that this has from a pulmonary perspective alone, when you look at things like disability, years of life lost, and deaths, COPD, lung cancer, and lower respiratory tract infections and asthma are a huge majority of these cases. And this is not even including things like patients who are presenting with sepsis and shock from pneumonia and all of these things. I mean, when you look at the impact that this has, it is obviously huge. And this is data from 2013, but we see that this still continues to be prevalent. So we all kind of have a sense for what COPD is, but how Gold defines COPD is that it is characterized by persistent respiratory symptoms and airflow limitation. And those are due to airway abnormalities usually caused, not always, but usually caused by exposure to noxious stimuli. And the most common symptoms are dyspnea, cough, sputum production, and often associated with extrapulmonary manifestations. Dr. Wells talked a little bit about how, the impact that lung disease itself, even outside of the steroid treatment, can impact your musculoskeletal system, your bones. You see significant amounts of weight loss in these folks, and that's not just from metabolic rates and malnutrition. It's also about increases in the inflammatory process related to COPD. So TNF alpha and all these other inflammatory mediators are ramped up, and you have significant amounts of weight loss. And we see our end stage COPD patients start losing a dramatic amount of weight. And it is partially because they're trying to run a marathon essentially while they're breathing, but it's also because of the upregulation of these factors. So the main risk factor in the United States is smoking, but elsewhere, particularly in India and Africa, it is related to biofuels and pollution. Indoor cooking is actually a big one in those countries. And then you can also have abnormal lung development and accelerated lung aging be a risk factor for developing COPD, or at least contribute. And then, of course, we all know or have heard about alpha-1 antitrypsin deficiency, but there are mutations in genes that then lead to the alpha-1 antitrypsin deficiency and will cause accelerated emphysematous change, among other things. And so we see that often enough as well. And we are learning with alpha-1, as many of you probably have experienced in your clinics and things, that when we are screening for alpha-1, we are finding alpha-1. It is much more prevalent than we think. And so that is something that we definitely need to be working into our guidelines for the workup of COPD. So what is this GOLD? We keep throwing this term around. What is GOLD? Well, so in the 1990s, the World Health Organization and the NIH kind of got together and said, hey, let's take a look at the data and where we are heading globally with COPD. And what they found was that probably by 2020, COPD was going to be the third leading cause of death globally. Sadly, the United States reached this by 2009. So in the 1990s, this was becoming a thought. And the World Health Organization and the NIH kind of got together to help standardize the care for patients with COPD. And it's been a fantastic thing. There's been an amazing amount of evidence-based research and guidelines that have come out. And then they come out with these updates and these reports intermittently. And so that's what we're going to talk about mostly today. Here is that GOLD 2017 report. So this was the biggest kind of shift with, recently with the GOLD guidelines. So prior to this update, what we were doing is we were doing spirometry on people, and we were saying, okay, you've got an FEV1 of 30%, and we're going to treat you with this medication because of this number. We weren't necessarily taking everything into account with what their CAT scores were and their MMRC scores. So you'll see this. Hopefully everybody can see this slide, but on the bottom of this slide, you have A through, on the bottom right-hand side is where I'm pointing. You have A through D here. And then you have your MMRC scores and your CAT scores. What those scores are, similar to what Dr. Wells talked about with asthma, we have validated instruments to look at COPD, to see kind of the level of shortness of breath and the impact, the amount of symptoms that they are having. And so the CAT score is what we use in my office. And generally we use the cutoff as 10. So lower numbers are better, higher numbers are bad. And we use it every time a patient comes into the office, even if we have a baseline CAT score for them. That's what it is. It's a baseline. So we want to see where they are, and you'll be surprised how many times they answer it significant. I mean, the scores vary incredibly based on how they are feeling that day and how that ends up correlating with their risk for exacerbation or their hospitalizations. So we in 2017 first started to incorporate and understand the importance of symptoms related to COPD, but that was also the first time we started working in exacerbation history into our algorithm on how to treat this. Because what ends up mattering at the end of the day, it's, do patients feel short of breath, and do patients end up in the hospital? You know, those two things are the biggest predictors of mortality and survival and quality of life, and all those things that we look at. Those two things are huge. So that's why we have decided to, why we decided in 2017 to start placing more emphasis on this and kind of separating spirometry out a little bit. So you'll see that here we have kind of moved this FEV1 % predicted of your, the severity of your COPD separated from what group you end up into. So that was a huge thing. This was also the first time that we started emphasizing, well, maybe we should de-escalate treatment. You know, maybe we should not throw everybody on triple therapy and then just leave them there. Maybe we should have an algorithm to start working down and weaning these people and consider de-escalation. So some of these things, as we go on, we learn that these are important parts of treatment for COPD. Now, here comes 2023, and we've learned so much more. And what we've taken is, if you look at that bottom right-hand corner of this slide from gold, we have now taken out groups C and D, and we've just turned it into E. And that makes sense for a lot of reasons. One, we're talking about exacerbations. So E is easy to remember. The patient has had at least one hospitalization that is an exacerbation. And so we know now, as we've seen this over and over through the years, patients that end up in the hospital with exacerbations need significant amounts of treatment, and that helps guide our treatment. We still have the CAT score / MMRC, and I don't know, does anybody use MMRC in their clinics? Or no? I think mostly what I've seen mostly is CAT scores. MMRC is a little bit simpler. It's a little bit easier to administer, less questions. The CAT score asks questions about energy. It asks questions about sleep. It asks questions about how well you're getting up a hill. It asks questions about cough. These are all things that are very, very important in our patients with COPD, obviously. And so, so that's something that we administer every time patients come in for follow-up for their COPD. Healthy or not, we ask them those questions. We have it in the chart, and then we scatter plot them. You know, we make sure that we understand where the range is with these patients. We still look at the FEV1 and make sure that we take that into account. But again, not to belabor the point, but I have patients who have a FEV1 of 25% that have had 0 exacerbations, 0 hospitalizations. Their shortness, their CAT scores are like 5. They are limited, but they get along just fine with that level of obstruction, which is crazy to think about sometimes, but that happens. On the other hand, we have patients that have an FEV1 of 60%, and they're in the hospital 5 times a year, you know, and there's just, so it is the hospitalization and the patient's own reported symptoms that matter the most. Okay, let's jump into treatments for COPD. So who has read who has read this book or have been read to with this book? Okay, so when I was in fellowship, I have a friend who basically was so frustrated by all the llamas and lavas that he ended up rewriting this book to make it all about COPD treatments. That's what nerdy pulmonologists do. And we all sat around and we all contributed. We all wrote pages. It was fantastic. But this is what this is. It's Llama Laba COP drama. That's what we named this book. Okay. So there is a lot. Pulmonologists love their acronyms, right? If you talk about ILD, or interstitial lung disease, we have a billion different acronyms, right? We have DIP, LIP, UIP, IPF, all of these different acronyms for these diseases. Similarly, with treatment for COPD, we have lots of different acronyms, and it can get confusing. And even for you guys out there that are administering these medications to your patients on the floors or in the clinics, or helping with teaching or whatever you may be doing with these medications, it does get confusing. And you put these charts up there for patients on the back of the doors with all these inhalers. And when you're talking to patients, they are saying, well, there's 100 different inhalers out there. Why aren't you trying something else? There's a frustration from some people. And so oftentimes, I think it's really important to simplify it in plain language for patients on what these groups of medications do. And we'll talk a little bit about that on the next slide. But basically, you have SABAs, LAMAs, SAMAs, LAMAs. Okay, right? So short-acting beta agonists, like albuterol and Xopenex. You have LABAs, which are long-acting beta agonists. You have SAMAs, which are short-acting muscarinics, and you have LAMAs, which are long-acting muscarinics. So those are some acronyms that people just bang their head against the wall about, right? But that's kind of the baseline. And then you have these combo inhalers, which makes everything else more difficult. So here's what I tell patients, and take this, I mean, if it's useful for you, you can do this, but I think it's really important to just speak plainly with these patients, because part of this is gimmicky with the pharmaceutical companies that make these medications, and part of it is real and very, very helpful to have all of these different inhalers that have different devices. You have the ellipta device, and you have an aerosolizer, you have a discus, you have a Respimat, you have, I mean, all these things. The patients don't, I mean, they're just kind of like, give me something that works, right? But we know the nuances of these different devices, and maybe what might be better in terms of their inspiratory capacities, whether they like a dry powder or aerosol, whether they would be a patient that would be better with a once-a-day dosing or a twice-a-day dosing. So those are all things that we should be aware of, and it's nice to have these options. But generally, I tell patients, look, there's only 3 types of treatments out there for COPD and asthma. Well, outside of biologics, right? Outside of biologics, there's only 3 groups of medicines out there. You've got a dilator, and the dilator pops those airways open. You've got an agent that relaxes the tone of the airways. Those are your muscarinic or anticholinergic agents. So they relax the tone of the airways, and they help air flow through, so you can breathe better. And then the third one is an inhaled steroid, and that decreases the inflammation in the airways. So if you just tell patients that they're like, okay, you've got 100 choices out there, but they all fall into one of those 3 groups. And there are differences in terms of how long they last. Some are long-acting dilators, some are short-acting dilators. So albuterol, because you have these patients like, well, my friend has this inhaler, and then this one, and it's just, to me, that's been very useful. And I think just understanding that we do not want to overlap, as much as possible, we don't want to overlap those 3 groups. And if they're on those 3 groups, then they are adequately covered for their disease if they have severe disease. And if they're not on those 3 groups, then we have some room to go. So we kind of talk through that a little bit. And combo inhalers, we have good data to support that patients who are on combination therapy, actually the compliance is better, and we all know ourselves, and if you have to take multiple inhalers multiple times a day, versus one inhaler once a day or maybe twice a day or something like that, it's just easier instead of grabbing multiple different inhalers. So actually Gold has good data to support that that is the case. So we have been moving more towards combo inhalers. There's been a lot of great research about triple therapy inhalers. So we at Methodist will use Trilogy as our inpatient triple therapy inhaler, but then there's also Breztri. So there's a lot of different treatments that, again, there are nuances to these, and there are very important differences between these in terms of dosing, tolerability, oral, thrush, and all these other things that you get is important, but they all fall into one of those three categories, essentially. Okay, so let's talk. These slides, these next few slides are straight out of the Gold teaching set 2024 guidelines based off of the 2023 report. So here it is again, that group E on top. If you have 2 or more moderate exacerbations or 1 leading to a hospitalization, you are group E. Now, you see that little disclaimer under your LAMA plus LABA. It says, consider an ICS if your eosinophils in your blood are greater than 300. So here's those eosinophils again, right? We've talked about that with Dr. Wells's lecture, and this is just going to be the future of pulmonary medicine. Eosinophils and the inflammatory cascade plays such a role in exacerbations and the disease process that we do recognize if you are eosinophilic, you would benefit more from an inhaled corticosteroid. So, and there are some obvious side effects of inhaled corticosteroids, and so that's an important factor to consider, and that's why we use that. So generally, this has been very, very much simplified. LAMA and LABA is the way to go. So examples are going to be things like a noro. In our system, noro is a LAMA plus a LABA. So there are, again, different ways you can combine these medications to reach group E treatment. But so many of these patients end up being on triple therapy. The other thing that I will say about this whole eosinophilic conversation is that there are a lot of confounding variables on why you may not be eosinophilic, right? A lot of these patients are on systemic steroids, and they are suppressed, and we may not capture them at the right time of being hypereosinophilic. And so that's something to keep in mind is if a patient's been hospitalized 4 times, and then you're seeing them after their 4th hospitalization back in your office, and you're seeing them 1 month post-hospitalization, and they've been on a steroid taper that ended 3 weeks ago, and you do a CBC, it's possible that their EOs are still suppressed, right? So those are things that we have to keep in mind as we're trying to make these decisions on bronchodilator therapy. But basically, if you're group A and you have low shortness of breath scores and you have low exacerbations, outpatient or inpatient exacerbations, then a bronchodilator is adequate for group A, okay? But otherwise, if you are group B or group E, you're talking about LAMA, LABA therapy plus or minus an ICS based on your eosinophils. So the recommendation now in Gold also is to say we need to then, for patients that have exacerbations, we need to follow this algorithm. And this algorithm is kind of here on this right side, where basically we, again, are looking at the eosinophils. And then we're saying, okay, well, if you're on a LABA, you can add an ICS if you have that greater than 300 eosinophils, but you can also consider it if they're still having persistent symptoms. You can also consider it if your blood eosinophils are greater than 100 even. So basically, if there is some level of eosinophilia, this is something that you should consider adding that ICS. And then for patients who are refractory, they have worked into their algorithm 2 separate additional adjunct treatments. One would be azithromycin, which we do as a low dose, as a daily low dose treatment, or Dalaresp, which is a PDE4 medication that basically helps decrease exacerbations. azithromycin, if you're going to do daily azithromycin, low dose azithromycin treatment, the recommendation is to do it preferentially in patients that are former smokers, not who are actively smoking. And there are various reasons for that. But, azithromycin is a great antibiotic for respiratory infections, but it also comes with its own problems, right? I mean, you have to do hearing testing, right? Patients can develop tinnitus and ringing in their ears about being on azithromycin or this class of antibiotics. You can develop resistance patterns, and a lot of these folks end up having recurrent respiratory infections, and this definitely it can be problematic. So something to keep in mind if you're going to be considering azithromycin dosing. And then Dalaresp, these are patients generally with FEV1s of less than 50% and have chronic bronchitis symptoms. I'll tell you that, a lot of, I haven't had great luck with coverage of Dalaresp and with really response to Dalaresp. I mean, that's me personally. I realize it's worked into the guidelines. Theoretically, I think it's supposed to help. Just what I have seen clinically, I just don't have a ton of success with it. And patients really do have bad abdominal GI symptoms with the use of Dalaresp. So cramping and diarrhea is sometimes limiting for these patients. And so sometimes I'll start this off lower dose every other day or every 2 days and then kind of titrate up for these patients. But again, not something that I've been sold on personally. Let's talk about oxygen, because this is something that we all probably deal with as well. Setting up oxygen, and seeing patients on oxygen in our offices. And this is something that I have tried to hone in a little bit with my clinic, because we do place a lot of emphasis on our patients with oxygen compliance. And I do think it's important. When I was in fellowship, I had one of my mentors tell me that when they were in fellowship, they did a opinion article that was published in Chest about what it's like to be a patient on oxygen. And so he basically took the oxygen tank and took his cannula and just carried it around with him for X amount of time, and basically journaled his experiences with how, what his life was like before and what his life was like after, and how people treated him, and how hard it was to go sit in a movie theater or go out to dinner or whatever it is, and the limitations and it was a really good opinion article. And I would encourage all of us to think about those things when we are talking to patients about, and not necessarily dismissing, oh, you're just not wearing your oxygen, like you don't care about your, there are real challenges to wearing oxygen all the time, the way that we titrate them. But when you come back and you look at the data, when you look at this, the long-term administration of oxygen increases the survival in patients with severe chronic resting arterial hypoxemia. We have level A evidence for that. That is absolutely clear. But in patients who have stable COPD and moderate resting or exercise-induced arterial desaturation, prescription of long-term oxygen does not lengthen time to death or first hospitalization, or provide sustained benefit in health status, lung function, and 6-minute walk distance. So it has, in patients that are stable, it has a very, very little impact. And again, level A evidence that has a very low impact. So part of the reason I put this in here is, and I try to remind people in my office this as well, is, we have to be, I think it's important for us to be advocates for our patients and say, hey, you should be taking your medicines the way you're supposed to. You should be using your oxygen, but also understanding some of those real life limitations with doing so. It is hard. And if we have good evidence to say that it may not matter a ton in those patients who have stable COPD, then we'll keep that in mind. So that's just something that I think, GOLD is recognizing. It's something that we should be recognizing as well. And then they have some good evidence on ventilatory support as well in patients that have COPD. and non-invasive ventilatory support may improve hospitalization-free survival in patients after a recent hospitalization, particularly those with pronounced daytime persistent hypercapnia. So good evidence to support those patients with exacerbations and severe COPD and hypercapnic respiratory failure. We define arterial hypoxemia as a PaO2 of less than 55 or an oxygen saturation of less than 88. And that changes slightly if you have right heart failure or erythrocytosis, but that's generally our cutoffs there. And then the recommendation is to recheck in 60 or 90 days to assess and make sure that your oxygen is still needed. And then looking at other pharmacological treatments in these patients with COPD is important. So alpha-1 antitrypsin therapy is something that's a whole different conversation, but it is something that can very much help. This is interesting as well. Antitussives, we all talk about, like, there's people who swear by Mucinex and people who swear by some of these antitussives, and that's okay, and so what I tell my patients is, if it is working for you, then use it. I think that's important, and it does. There's patients that really, those types of therapies really make a difference, but there are patients that it doesn't, and the evidence would suggest that there's not really any conclusive evidence that there's a big beneficial role in that. So we can use it as a tool in our tool belt to treat these patients, but that's not something that we should necessarily make sure that every patient has, because you just have to take those one at a time. Opioids, low dose, long acting opioids in patients that are being treated for severe dyspnea are beneficial, and we do see that people have significant improvement in their quality of life. I generally reserve that for the very right patient with significant advanced COPD. But that is something that should be considered as well. Vasodilator therapy does not improve outcomes. And then there are some drugs out there that are approved for patients in pulmonary hypertension, with pulmonary hypertension. There's actually one or two, like Tyvaso is one of them, that actually works with group 3, WHO group 3 pulmonary hypertension, which basically means it's related to lung disease. And you can potentially have some benefit from these drugs. All right, let's go through some cases and I'll wrap up here. Okay, Joe Broncos. This guy is 63 years old. He's got a long-standing tobacco abuse history. He comes into your office for hospitalization follow-up for shortness of breath and acute COPD exacerbation. He's had Spiro before, and it shows that your ratio is 68% and your FEV1 is 32%. For those of you who are not used to reading pulmonary function studies, that means that he is, by non-Z score standards, has obstructive lung disease, and the severity of his obstruction is pretty bad. 32%, we would call that severe COPD. If he is not asthmatic and has reversibility, we would call that severe COPD. He is on no controller at home. He has had 3 hospitalizations this year for his shortness of breath. His CAT score is 19. So again, scores 10 or less on the CAT score is generally what we like to see. He has recently quit smoking. So which of the following should be done next? Should you take him for a bronchoscopy? Should you start Dalaresp, do daily prednisone as maintenance? Should you start LAMA-LABA treatment or start LAMA-LABA treatment, consider an inhaled corticosteroid, and refer to pulmonary rehab? So this question, I think, is fairly straightforward, but it is a patient who has no controller at home, and he has had 3 exacerbations, clearly continues to have group E symptoms with his CAT score of 19 and hospitalizations. And he has recently quit smoking, which would qualify him for pulmonary rehabilitation. And I think that would be the right ideal answer. It is not the wrong answer to start a LAMA-LABA and reassess and step up therapy accordingly. But generally, in a patient who is presenting this way, they have reached, that group E treatment and will likely need consideration for the addition of an ICS. All right, 83-year-old, blah, blah, blah. Basically, long, scenario. The patient has bad lungs, okay? Patient has bad lungs. 83-year-old, bad lungs, on triple therapy. daily mucus production, thick copious secretions, one exacerbation every 8 weeks. Calls you and says he's ready for his clean out bronchoscopy. Chest x-ray is clear. He is actively smoking. Which of the following should be done next? Well, I just gave you the answer. So start Valor. Okay, so you have these patients that really do benefit when they have obstructive airway disease and they're plugged and they're in respiratory failure, and you see that their lung is not inflating well, that can benefit from a therapeutic bronchoscopic evaluation and then a culture and all those things. And we do that sometimes in the hospital, but it really provides no benefit in outcome. And sometimes it can make patients worse. I mean, if you're going in there and doing these things, it can make patients worse sometimes. So we have to be, so that's certainly not a recommendation. Daily prednisone as maintenance is not a recommendation generally. De-escalating therapy at this point is not recommended. He's having one exacerbation every 8 weeks. And pulmonary rehab at this point, the patient is actively smoking, so would not necessarily qualify. So the recommendation at this point would be to start Dalaresp. Again, actively smoking, Dalaresp is a good choice for that patient. Which of the following therapeutic measures has no improvement on exacerbation rate? Inhaled corticosteroid, an oral corticosteroid, long-term antibiotic prophylaxis, or a pneumococcal vaccination. So it is oral corticosteroids. And that's why we have talked, both in Dr. Wells's lecture and my lecture, about how we try to avoid patients being on oral steroids. So you see some patients, and I have some patients admittedly, who are on 5 milligrams of prednisone a day, and they have benefited. And you try to take them off of it, and you can't get them off of it, and they exacerbate, and then they get put back on 5 milligrams of prednisone. That is generally not recommended to do things that way. But I also have some patients who I know, by just looking at them, looking at the numbers, looking at their history, they're going to die in a year or two. And it is about symptom management and risk versus benefit. And so if you sit down and have that discussion with these patients and you say, you're going to be at higher risk for a fracture, compression fracture, hip fracture, muscle wasting, diabetes, skin changes, eye changes, like you go through the whole thing. But you might feel a little bit better for however long you live. That is a conversation that I have with some patients, and I think that that's okay. If you have that conversation, you understand it. But if you look at the data, it really has no improvement on exacerbation rate. Quality of life is a separate thing, and that's just something between you and your patient you should discuss. So that's all I have for you guys. Don't hate, ventilate. Tell me what questions you guys have. Any questions? Yeah.
Recently, my brother-in-law was put on home oxygen after pneumonia and new diagnosis of COPD. Wanted to, it would be so much easier for him to get around if he could get portable concentrator, but it seems like it's a really difficult thing to make happen fairly quickly. Is that, he lives in Southern Missouri, is that true around here too? Or?
It is, yeah. This is something, I'm sure a lot of the office folks and respiratory therapists can comment on this as well, but this is something that we deal with constantly. So much of it ends up being about insurance contracts, and many times many insurance companies will basically cover one or the other. So portable oxygen concentrator is oftentimes seen as a convenience item, right? So that is something that if they have a home oxygen concentrator that makes its own oxygen and portable tanks, sometimes they will not cover a portable oxygen concentrator. Now that is changing, and I think Terry, correct me if I'm wrong, but there are some changes that have happened with that with some insurance companies, right? Okay. So there are ways, and it gets confusing where, you have patients that are like, well, I know so-and-so, and they were able to get a portable concentrator, and my insurance, so you have to go through that. You have to advocate for them. But generally what I tell them is, this is kind of how insurance companies work with the concentrators. If you have a home concentrator, it is kind of considered convenience item, the portable tanks. But I have a lot of patients who invest in Inogen, and that's maybe what I'm thinking of is the Inogens are now, some companies are covering the Inogens and not cash paying for it. But there are devices out there that are smaller, more convenient, and would be more beneficial. But yeah, it is a process with insurance companies and contracts and yeah, all of that. Good question. Any other questions?
I have
Yeah.
a question. So say you have your old typical COPD or Flonasum, Flonasum, do you not prescribe NEBs 4 times a day anymore for them if it helps to clear them out?
Yeah, we still prescribe NEBs. Yeah. Are you talking about which NEBs are you talking about specifically?
DuoNeb.
Just DuoNeb. Yeah. Yeah, we do. And what I'll say about DuoNebs is sometimes you have to be a little careful on patients who are already on triple therapy. So if they're already on anticholinergic and they're getting albuterol and ipratropium within that DuoNeb, you can get some toxicity. We don't see it as often, as you do with like if you're on tiotropium and you're getting ipratropium, we don't see that as often with that type of toxicity when you're on like a different type of anticholinergic and a DuoNeb with ipratropium. But it is something that you have to watch for. And, remember too, a lot of our patients are elderly and they have gait instability and they have all these things. And so we have patients that swear by their nebulizers and take them around the clock. And if they're doing it mostly to help improve expectoration, and then they're all shaky and they're walking around, you have to be a little careful with that. And I generally try to move more towards chest physiotherapy, and flutter and all those things if we can in those patients to help expectorate. But yeah, no, I think NEBs are always a good adjunct.
Are
Yes.
you increasing the best therapy with COPDers?
Yeah. I think that it is something that now, in patients that don't necessarily have like cystic traction, dilated bronchiectasis, they can still get qualified for a vest to help with expectoration, but it is still a process. Again, you guys probably in this room know this better than I do in terms of the barriers sometimes with approval. Those are expensive, and you usually have to go through flutter and all these other things to make, to say that you have failed before you qualify for that. But absolutely, there are so many of those patients that benefit. Yeah, great question.
I have a couple.
Yeah, sure. Yeah.
First one is, you guys have a process for, we have a lot of patients going to Colorado or whatever,
Mhm.
oxygen while they're there, but can't prove it here.
Mhm.
So they usually end up paying out of pocket for like UC.
Uh-huh.
Do you have any
Uh,
magic way to get them qualified?
that's a good Terry question.
Okay.
Yeah.
Yeah.
Okay.
Yeah.
And then the other one is, I was just wondering your thoughts on hypertonic saline nebs for expectoration. Our doctors are pretty mixed on it.
Yeah, and that's exactly how it plays out with the data, is that there's, again, very similarly to mucolytic therapy, there's just not the data that supports the outcome, but you will see patients that swear by them, and you will see patients that have a dramatic improvement with them. And I would say I try it in everybody just because to me, it can't hurt until it does. And the hurt is essentially patients complain of burning. They say that they just feel like they're raw in there. And it's a pain, I mean, patients are sitting in front of their nebulizer for a long time and doing these treatments. But for those who it helps, absolutely. I'm a big proponent with that. But also a more specific population, and generally that population is in like MAC disease, patients with bronchiectasis, and those types of things. Yeah. Yeah, good questions. Anybody else? All right. Well, thank you for your attention, guys. Appreciate it.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.